And good afternoon, ladies and gentlemen. It's a great pleasure to be here with you today for two reasons. First of which is, this is my first in-person conference in 2 years. It's so nice to be back doing in-person events. Zoom is lovely, but it's great to be actually here in person with you here today. So that's the first thing. And the second thing, it's especially nice to be back in Dubai, because my last international conference, my last international travel was 2 years ago in Dubai. And I remember coming home from that trip and I heard a news briefing that there'd been an outbreak of this strange new virus in the hotel where some Italian cyclists had been staying. And even then I couldn't really imagine what then happened. That within weeks, international travel would have stopped, that I would be teaching my children at home, that offices and shops would be closed. It's been a quite extraordinary couple of years for this world. And it does seem that we are starting to emerge from this crisis. And what I want to do with you today is talk a bit about some of the lessons we've learned from this crisis, what this tells us about how do we build more resilient societies in the future. Because we know COVID hasn't gone away. We don't know when the next variant will strike or when the next pandemic disease will strike. We have to learn the lessons of this crisis so we're prepared for next time and future crises like these. We have to harvest the knowledge that we have to build more resilient societies that can cope with this type of crisis. Now, what I wanted to do today with you is share some insights that my organization has got from this crisis about how do we build more resilient societies. But let me say very clearly is I'm not here to talk about science. And of course, the scientific achievements during this pandemic have been absolutely phenomenal, both in terms of developing vaccines in record time, delivering those vaccines, and also in terms of evidence-based medicine in discovering where the most effective treatments very quickly. So I want to honor those achievements and also honor all the fundamental science on which this is built on. This has been the medical breakthroughs of the last 2 years are built on the work of hundreds, thousands of PhDs that seemed arcane and irrelevant and nothing to do with the real world, but have actually helped lay the foundation for our medical response to this crisis. But that's not what I want to talk about. I want to talk about the real world, real people, the social aspect of this crisis. And I want to do so on the basis of the work of my organization, the Social Progress Imperative. So let me begin by telling you a little bit about who we are and what we do that informs how we approach the COVID crisis. The Social Progress Imperative was created about 10 years ago on the back of the last global crisis, the global financial crisis of 2008. And we came together as a non-profit organization to say, we've got to think differently about how we measure the progress of our societies if we're going to build back better. And we developed a tool called the Social Progress Index. So this is a comprehensive measure of the real lived experiences of the people of a country, based entirely on non-economic indicators. So we're trying to measure not through the lens of how rich you are, but on the real quality of life of citizens, based around 3 fundamental areas. First of all, does everyone have the basic needs of survival? Essentially food, water, shelter, safety. Secondly, does everyone have the building blocks of foundations of well-being? Education, information, health, and a good quality environment. And finally, does everyone have opportunity in terms of rights, freedoms, inclusiveness, and access to advanced education? This framework, although it doesn't look like the SDGs, very much reflects the underlying concepts within the SDGs themselves. So the Social Progress Index is a tool for tracking progress against the SDGs. And maybe just to share with you some good news, we do find that since 2011, when our measurement starts, the world actually has been making some solid progress. The world as a whole, 163 countries weighted by population, has shown some solid improvement in social progress over that period. The majority of countries have actually got better over that period. That's the good news. The bad news is that it's not fast enough. On current trends, on this trend, we will not hit the SDG targets until 2082, 50 years too late. And if we factor in the potential impacts of COVID, that adds another 10 years. So the path that we're on is not going to take us anywhere near the SDG goals by 2030, even though progress is occurring. And one of the things that our data shows us is that if our model is based on economic growth alone, it's not just going to get us there. What I've done here is just simply plotted all the countries of the world with their social progress score on the vertical axis, and then the GDP per capita on a horizontal axis. And what this shows us is that, yes, getting higher GDP per capita is broadly good for social progress. Yeah? Especially for poorer countries, a bit of extra GDP means you can afford more roads and nurses and teachers and books, etc. Economic growth is a good thing, but it's not the whole story. GDP is not destiny. At any level of GDP per capita, there's opportunities for more social progress, risks of less. And those countries that are above the line are broadly doing a better job than those below the line in turning their wealth into social progress. And what we've been doing as an organisation is working around the world with a whole range of partners to use this data to try and help governments and businesses think about ways of creating more inclusive and sustainable ways of working to accelerate progress towards the SDGs. So that's an introduction to the work that we're doing. So when COVID struck, we thought, well, what insight can our data provide on how the world is going to confront this new COVID crisis? And the first thing we did was we thought we'd have a look at resilience to epidemic diseases. Because there'd been a bunch of work done trying to compare countries in terms of their resilience to epidemics, in terms of their medical capability. What's the quality of their universities? What's the quality of their laboratories? And we thought, well, actually, if you're going to resist COVID, if you're going to be resilient to COVID, it's about more than just technology. It's got to be about your social institutions. It's got to be about whether you are an equitable society. So we took our social progress data and had a look at three particular components of our model. First of all, shelter. If people are going to do social isolation, protect themselves from infection, they need somewhere to shelter. So housing and shelter is really important. Similarly, water and sanitation, the ability to stay clean, to wash your hands, we saw as a key barrier against COVID. If people don't have access to clean water, if they don't have good sanitation, they're going to be more vulnerable to epidemic disease and to COVID. And thirdly, we thought, well, fundamentally your health systems. Do you have a decent health systems in place? And do you have what's the health of your population? So these three components of our existing model, water and sanitation, shelter and health and wellness, we combined together as a measure of what we called Social Epidemiological Resilience, because we couldn't think of a better name. And when we looked at that, we saw that that measure did show a significant relationship against infectious diseases in general. Not COVID, because COVID was only a new phenomenon then, but it did seem that these factors had a significant relationship with resilience to infectious disease. Okay? And then we said, okay, well, how are countries performing? And what we found was that the best performing countries were actually quite an interesting mixed bag. All tended to be higher income countries, no surprises there, but perhaps not with a normal ordering of who are the richest countries in the world. Perhaps I can show it more clearly here. These are the high income countries that are clustered together. And we see that there are some very rich countries that are not doing such a good job in scores. One in particular I'd highlight is the United States. The United States has phenomenal laboratories, phenomenal researchers, phenomenal hospitals, but it's not doing so well in terms of those basic building blocks of resilience. And that was reflected in this less good score, not being in the top 20 countries in social epidemiological resilience. And we could then break this down by different income groups. We could see upper middle income countries. There was a wide range of scores. Costa Rica in particular performing best. More on Costa Rica to come. And then for lower income countries, a very wide spread of scores, from Tunisia doing best to Papua New Guinea worst. And then for lower income countries, again, a wide range of scores, lower performance there. So we see that there's a wide range of possibilities of this resilience to epidemic diseases. Now, what we need to do later on is actually analyse and how much this reflects actual performance against COVID. Because I think we have to see that it's still unfolding to get reliable disease estimates on infection rates, death rates, etc. But it does seem that there was some insight there about the resilience to these diseases was about certain social factors. And that was what was highlighted in our data. But we knew that wasn't enough. Because we knew that something that was missing in our model was about fundamental vulnerabilities to COVID. We knew very early on that being older, having underlying morbidities, would actually make you more vulnerable to COVID. So we developed another tool which we call the COVID Vulnerability Index that we developed for the United States. And the idea here was to build a measure of what's your vulnerability in terms of your population. And that was across 3 different dimensions. First of all, do you have a basic health infrastructure to make sure that people have got access to healthcare if they need treatment? Secondly, what's the underlying health of the population? Do people have these morbidities that were associated with higher mortality rates from COVID? And thirdly, what's your demographic breakdown? Do you have a lot of older people in your population? Because breaking it down like this, it was helping us to understand what are the underlying risks within a society. We had a data set that covered the 500 largest cities, and within those cities down to the level of local neighborhoods called census tracts, 28,000 census tracts. And what we found was that there was a very wide range of vulnerability across different cities that wasn't just explained by income. The most vulnerable city in the United States actually turned out to be Gary, Indiana. So this is an old Rust Belt city. It's got an older population. It's got a lot of underlying morbidities, and the health infrastructure is not so strong. So some of these, we found this in general, of some of these older post-industrial cities had a lot, sort of blue-collar cities, had a lot of the vulnerabilities that were going to make them more prone, more at risk of infection from COVID. We then found some of the best performing places were like, I think, College Station, California, and some others. Tended to be university towns with a younger population, a fitter population, good access to healthcare. So a wide range of performance on vulnerability, a wide risk profile for different cities. And then what we also found was there was enormous variability within cities. Just to show you a couple, here's I think Atlanta, here's Miami, and here's Chicago. Each of these cities showed extreme levels of difference in vulnerability across different neighborhoods. So even within one city, you couldn't assume that the same interventions would work, because some communities would be much more vulnerable than others. And when we analysed this data, we found one very interesting trend, which was we looked at the vulnerability score against the percentage of African American population, and we found an important, significant relationship there. And this tells us a critical thing about the COVID crisis, is it's not just about the virus and its infectiousness. It's also a virus that feeds on underlying inequities. So the inequities of poverty and economic lack of opportunity and poor social outcomes, poor health outcomes that have confronted the African American population have in turn made them more vulnerable to COVID. So COVID actually has shone a light on the many inequities in our societies and how there are challenges we have to address in those terms. And so it also tells us that societies that have greater inequality like this, greater deprivation, greater marginalization, are likely to suffer more from the COVID crisis. So that was our second piece of analysis, looking at the vulnerability to COVID of different communities. The next piece of work we did was actually trying to integrate some of this together, and what we call the COVID-19 Integrated Risk and Response Tool. This was a piece of work that we actually developed in partnership with the government of Costa Rica. And I was fascinated in the last panel where people were talking about how there's this fragmentation within the SDGs and within our governance structures, that health ministries might not talk to education ministries, who might not talk to finance ministries, etc. That is a big problem. And Costa Rica, which actually is one of the countries that's doing a very good job at turning its GDP into social progress, actually quite quickly grasped the need for an integrated response to COVID-19. As some of you will know, Costa Rica is a country that abolished the army 70 years ago. It's had a very inclusive policy for many years. It introduced universal primary education in the 19th century. It introduced higher education for women at the end of the 19th century. It's got a very strong social sector. So whereas much of Central America it has many problems with governance and is in crisis, Costa Rica is sort of an oasis of good governance that's got a very human-centered government. And so they came to us, to our partners at the Inkai Business School in Costa Rica, and said, help us, join part of our National Emergency Crisis Room, working with the President to understand how do we manage this crisis. And one of the first things that we realized we had to do was to see this was not just a health crisis. This had to be an integrated response that also was based on insight from a local level. Because as our experts put it, is that what really you've got to combine the different dimensions of this crisis. Yes, there's a health crisis, but there's also an economic crisis. If people are out of work, if their income, livelihoods have collapsed, that's a challenge. And then there's a social crisis in terms of poverty, in terms of people being left out of schools, all those different factors. You've got to integrate that together into your response, and you've also got to base it on real local insight. Because if you can think of all the interventions you like, but the interventions have to be based on understanding of the local context. And that's what we were trying to do, was develop insight into the local context on a local basis in Costa Rica to help the government inform its response. And that was then the basis of what we call the COVID Integrated Risk and Response Tool. And here's the basic model. So first of all, what we had to do was take some indicators around the social conditions of the population. So things like the poverty rate, but also other indicators of deprivation. Understanding each community's social position helped you understand a set of risks and also dynamics of how they were likely to behave in response to the crisis. Secondly, economic dynamics. What people do for a living, what kind of job they have, is going to have a huge impact on how they respond to various restrictions. So what are the economic dynamics? Are people employed? Are they self-employed? Do they have insurance? Can they work from home? These kind of economic dynamics are critical. Thirdly, the underlying health factors. As we saw in the vulnerability index, things like the age of the population, the morbidity factors of the population, the existence of health facilities. That's the third part. And then the fourth piece was actually around some of the demographics, not in terms of the population profile, but what's the population density? If I'm living in a densely populated city, then my risk of infection is going to be much greater than if I'm in a rural area. If I'm in an area where there's lots of movement of people, then that's going to mean greater risk of infection. So this was the fourth pillar of this model, the social interactions and population density pillar. And then we took metrics for each of these four aspects and combined them together to produce the integrated risk and response tool. And this is a bit of how it was being used. So what we could do then is take each of these indicators. We take an aggregate score to talk about what's the risk profile, where are the highest risk areas, where are the lowest risk areas. What we could then do is look across the different factors, how this is different counties of Costa Rica were performing. And so you could see that some were more risky in some areas than others. Some had different risk profiles. And this was the data that the Costa Rican government was then using to understand the crisis and think about its response. And on the basis of that, it could then customize interventions. So if you've got issues around poor social living standards of poverty, then ensuring that you've got food supplies to those populations could be very important to make sure they don't have to expose themselves to risk to go out to work and find other challenges, or ensuring that they keep their general health in a good position. You could also this point about access to information. The last panel talked about the digital divide. Do people have access to information to be able to understand the crisis, but also to be able to continue their economic life, continue their social life, etc., continue their education? And then also thinking about interventions to support different kinds of businesses, whether it was supporting employment, supporting small businesses, customizing that data to be able to make the right kind of interventions. Do we need to provide financial support to small businesses if they're being asked to close down? Do we provide loans, or do we provide other employment guarantees? Customizing the interventions based on this data. And then finally, looking at mobility. And I think one of the things we saw here with Costa Rica is that during public holidays, a lot of people naturally like to go to the beach. And so using this data on mobility, the Costa Rican government was able to anticipate when there were high-risk moments and introduce short-term travel bans or travel restrictions to try and reduce those risks. And by having a flexible, data-driven approach to this, Costa Rica was able to avoid very heavy-handed blanket restrictions, which are perhaps unenforceable, but also more forensic and targeted interventions. Forensic interventions that were effective burden on the population. And as a result, we have to say that Costa Rica has been one of the big success stories of the COVID epidemic. If you look at infection rates, if you look at mortality rates, Costa Rica has outperformed neighboring countries. Are we all right on the sound? Gents? We okay? Okay, good. So this is where the integrated COVID response tool was developed in Costa Rica. We've then taken that tool and developed to various places around the world. Gents, is the sound all right? Ladies and gentlemen. Are we okay? Okay. So this is an innovation that we started in Costa Rica, and then governments around the world have been taking it and using it and applying it in their own contexts. Just to give you a couple of examples, we did some work in India. So this is the integrated risk and response tool for states of India. And they've used this data in India, in particular to help understand vaccine hesitancy and to customize campaigns to promote vaccination in the country. And indeed, one of the interesting findings from India on vaccine hesitancy was actually people coming back and saying, I don't want the vaccine because someone needs it more than me. So sometimes we can assume that people don't want the vaccine because they are concerned about Bill Gates putting microchips in it or something, or 5G mobile signals. But actually, sometimes people can have an altruistic reason for not doing it. So by understanding the local dynamics has helped them to develop an effective campaign around vaccination and dealing with vaccination hesitancy. We've also done work in Mexico, looking at the very, very diverse patterns state by state of COVID risk within Mexico. And we've also done further work at a very localized level within states in Mexico to break this down to a more localized level. We've done work in Europe. This is Germany. And in Germany, again, we see this very strong east-west divide on COVID risk, reflecting, again, how there are some very different health fundamentals in these areas, but also some very different economic structures, different social needs to allow a response to the crisis. Finally, just one more, France. And again, France we see here, very different patterns, a bit like the United States, in this northern post-industrial area where you tend to have an older population, perhaps with more morbidities, you see a higher level of risk and alert. And so your response has to be different in those different contexts. But maybe I just want to take a moment to talk a little bit about somewhere I know best, my home city of London. And in London, we partnered actually with Facebook, because Facebook has a lot of real-time data about people's movements. And so we integrated Facebook data into the risk and response tool. So we're able to see the trends of people's movements at different times throughout the COVID epidemic. So first of all, the rapid drop-off when we get the first lockdown, and then the recovery in activity, and then drops again with each of the individual lockdowns. But what we were also able to see was how there were different patterns of behavior in different parts of London. So essentially, there were different people facing very different situations in lockdown. If I was a professional person living in the west of London, sitting on my Zoom in a large house with good internet connection, I was in much less risk than someone in the east of London, in a poorer household. Oh, here we go again. Thank you very much. This one's better. In the east of London, where you might have much more densely occupied houses, where you might have different generations living together, younger people living with their grandparents who have got greater risk from COVID. And what you may also have is people who have to go out to work more. Because, of course, some people did have to go out to work. Some people went and stayed in their offices so they could protect themselves and really reduce their risk from COVID. but other people who were working in the health services, working in essential supply services, working as drivers, had to go out there and work still. So people in those communities saw much greater levels of movement. So we're able to compare different parts of London. And here we've shown the average for London, but also one of the most deprived parts of London, the London borough of Barking and Dagenham, which is over here on the east side of this map. And what you see here in red is that Barking and Dagenham, one of the most deprived parts of London, showed a much, much higher risk profile than parts of South and West London, because you had these risk factors around mobility. You also had some underlying health issues and other social problems as well. And what this allowed the government in London to do was to target support to the boroughs that needed it most, to think about targeting restrictions in different ways that reflected those different problems, and also then to target vaccination strategies based on risk profiles. So if you've got this kind of insight, you don't have to just see London or a country as one big place with the same dynamics. It allows you to understand the different localized dynamics, which will then influence your response in terms of the epidemic response, in terms of the medical response, but from vaccination, in terms of the reducing the spread of infection response, in terms of restrictions on movement, but then also in terms of the social response, in terms of where people are most in need of social assistance or economic support. And that allows you to make a much more effective response to this crisis. There is one virus with many variants, but the way it interacts will be very different in different communities. And only by understanding those communities can we really be able to respond to them and be resilient. And also what we see is that fundamental lesson is that if we want to be resilient to COVID and other future epidemic diseases, then actually in its own right, equitable, inclusive societies do show a greater level of resilience. And I think just to conclude, there's one other thought that we haven't yet analysed yet, is that I think we've, in some ways, the last 10 years have been a period where there's been something of a celebration of the autocratic model of government around the world. A sense that perhaps the autocratic governments are able to get things done in a way that democratic and open societies have not been able to do. And in some sense, the case of China perhaps illustrates this case, in terms of China's ability to stop the COVID infection and sort of eliminate the spread of the virus within China. In some ways, it has been a remarkable success, but also one that is almost impossible to replicate anywhere else in the world. And I think China will face some interesting challenges as it tries to emerge from this situation, and we'll have to watch the situation. But there's another pattern that we've seen in many of the other autocratic countries, is how they've struggled to respond to the COVID crisis because they haven't been able to get some of the feedback loops. One of the problems in analysing this, of course, is that some of the data is so unreliable. Certainly, sort of COVID data from Russia, I know, is particularly unreliable to understand what's really going on there. But I think we have to say that what we're seeing is that autocratic societies that don't have strong citizen feedback loops perhaps have not been so effective in responding to this crisis. And if we're thinking about resilience going forward, then it's not just around poverty or the social infrastructure or the medical infrastructure that we have to think. It's about whether we are open societies that can allow the flow of information, that can allow us to have an open conversation about challenges, will be a critical aspect of resilience going forward. Because this isn't the last crisis. This is going to happen again and again in different forms. And if we've got to find ways to make our societies able to respond to these faster. Medicine can take us so far. The vaccines are an incredible achievement. But we also have to build societies that are socially resilient if we're going to survive future crises to come. Thank you very much.